Good morning. On behalf of the research team, I'd like to thank you for this opportunity to present the results of our Children's Oncology Group study, focusing on comparison of self-report and electronic monitoring of 6-MP intake, that's a common oral chemotherapy given during maintenance therapy for childhood acute lymphoblastic leukemia. We know that durable remissions in childhood ALL require approximately 2 years of maintenance chemotherapy that relies on a backbone of daily oral 6-mercaptopurine or 6-MP. We have previously shown that electronically measured 6-MP adherence rates less than 95% were associated with a 3.7-fold increased risk of relapse. Accurate assessment of 6-MP intake is therefore crucial to ensure timely intervention for non-adherent patients. Although self-report of adherence may be a convenient and inexpensive way to monitor 6-MP intake in a clinical setting, the accuracy of self- or parent-reported 6-MP intake during maintenance therapy for ALL is not known. So in this study, we aim to address this gap in knowledge by comparing subjective or self-reported 6-MP intake to objective electronic monitoring, and by identifying the predictors of over-reporting of prescribed 6-MP intake. Eligibility criteria included patients with a diagnosis of ALL at age 21 or younger who were receiving 6-MP during the maintenance phase of therapy. We used a prospective longitudinal cohort study design with data collected over 6 months. The study was conducted at 87 Children's Oncology Group sites across the United States, Canada, and Australia. Subjective reporting of 6-MP intake was assessed using a self-report questionnaire that elicited the number of days that 6-MP had been taken over the past month. Patients completed the questionnaire if they were 12 years or older, and parents completed the questionnaire for children younger than age 12. A demographic questionnaire elicited race and ethnicity, parental education, and household income. Objective measurement of 6-MP intake was done electronically in the cohort using the Medication Event Monitoring System, or MEMS. In this system, a track cap is placed on each patient's 6-MP bottle. A microprocessor chip in the cap records the date and time of each bottle opening. Track cap data were downloaded at the end of the study period and compared with the self-report data. The objective electronic record was compared with the subjective self-report record for each study month. Patients were classified as perfect reporters if their self-report matched their electronic records for each study month, or over-reporters if their self-reported days of 6-MP intake exceeded their electronic record by 5 or more days for more than half of the study months. The remainder of the cohort was classified as others. We used multivariable logistic regression analysis to identify predictors of over-reporting. We included both sociodemographic and clinical variables in the model, as well as non-adherence, which we defined as a MEMS-based adherence rate of less than 95%. The cohort consisted of 416 patients who were a median of 6 years of age at the time of study entry. 2/3 were male, 61% were from families with average paternal education less than college, 38% had high-risk disease by NCI criteria, and 40% of the cohort met the designated criteria for non-adherence. The cohort included about 1/3 non-Hispanic whites, 1/3 Hispanics, and the remaining 1/3 of patients from Asian and African American ancestry. A total of 1,344 patient months of self-report and MEMS data were evaluated. Mean days of 6-MP intake by subjective or self-report are shown here by the gray bars, and mean days by electronic or MEMS monitoring are shown here by the green bars. The correlation by study month was moderate and ranged from 0.36 to 0.58. Using generalized estimating equation analysis, 6-MP ingestion by subjective reporting, as shown by this blue line, ranged from 25.7 to 26.1 adjusted mean days per month, while by objective reporting, as shown by this red line, the range was 22.8 to 25.4 days per month. Comparing self-report to electronic reporting by study month, we found that for 12% of the patients, there was no difference. For 24% of the patients, there was over-reporting by 5 or more days per month. Less than 1% of the patients under-reported by 1 or more days per month. And the remaining 64% of patients were classified as other. We developed a multivariable logistic regression model to understand the predictors of over-reporting 6-MP intake. We found that older age, non-white race, and lower paternal education were all independent predictors of over-reporting, and that the risk of over-reporting was increased 8.6-fold in non-adherent patients. In summary, in this multiracial cohort of children with ALL, we found that over-reporting of 6-MP ingestion is common. The large majority of participants in this study over-reported 6-MP intake at least some of the time, and almost 1/4 of them over-reported by 5 or more days in more than half of the study months. There was only a modest correlation between self-report and electronic monitoring of 6-MP intake during maintenance therapy, and those most likely to over-report included patients who were 12 years of age or older, those of non-white race and ethnicity, those from households with lower paternal education, and those who were non-adherent to 6-MP. We therefore conclude that subjective over-reporting of 6-MP intake during maintenance therapy for childhood ALL is common, particularly in non-adherent patients, and should be used with caution. These are our acknowledgments.